So welcome everybody to this Enter-Asthma webinar. We are privileged today to have with us Professor Michael Wechsler from the National Jewish Health. Everybody knows, I'm sure, Professor Wechsler. I think he's one of the leaders worldwide in regard to asthma. And today he will speak about some aspects of pathophysiology of asthma and some targets for therapy. So welcome, Professor Wechsler, and thank you for giving this talk.
Thank you. Let me see. Are you able to see my slides yet? No, thank you so much for having me today. Let me just share my slides again. Okay. And should be able to see them now. Can you see my slides?
That's fine.
Perfect. All right, thank you so much for joining. So we're at a very exciting time for the management of asthma. And in the last 10 to 15 years, we've learned so much about how to approach patients with severe asthma. And what I thought I'd do today is review some of the novel biologic therapies, some emerging therapies, and review some of the pathophysiology of asthma. These are some of my disclosures. So, as I mentioned, we've really evolved in how we have thought about asthma in the last several decades. In the 1960s and 70s, the focus was on bronchoconstriction. And then in the 1980s and 1990s, we started to utilize inhaled corticosteroids as we recognized the important role that inflammation played. In the early 2000s, we began to utilize the terms phenotypes and clusters to try to identify the types of patients with asthma and recognize that there were differences, that asthma is a heterogeneous disease. And we said, well, we can't treat everybody the same. And that's led to a more precision medicine-oriented approach, which we've just emerged in the last 10 to 15 years with identification of not just phenotypes, but also endotypes and other mechanisms of disease, including type 2 and non-type 2. And that's where we are now. We're doing a pretty good job in terms of identifying precision medicine approaches for our patients. I do think it's important to clarify the terms phenotype and endotype. A phenotype is the set of observable characteristics of an individual that result from the interaction of the genotype with the environment. And this is the outward manifestation of a patient. It's a characteristic that a patient can report to you. Am I allergic? Am I not allergic? Am I obese? Am I not obese? Am I a smoker or a non-smoker? These are observable characteristics. In contrast, the endotype refers to the underlying mechanism of disease. Now, a patient can't tell you their underlying mechanism of disease. They can't share with you their endotype unless you've had some type of evaluation and some type of measurement of biomarkers, including eosinophils and nitric oxide, propensity to allergies. That being said, the phenotype can inform the endotype if you have specific characteristics. For instance, if someone has childhood onset asthma, it's often allergic or IgE mediated. If they have adult onset asthma, oftentimes that's eosinophilic. But you can also look at comorbidities. Patients that have atopic dermatitis, for instance, might have more of an IL-4 or IL-13 driven disease. Patients who have urticaria might have an IgE driven disease. Patients who've got chronic rhinosinusitis with nasal polyps may have eosinophilic disease. So it's important to evaluate the endotype because the endotype allows us to evaluate what type of asthma a patient has and to personalize therapy and to maximize the drug response for our patients. So the question is how do we endotype? And we endotype our patients by utilizing biomarkers. And the biomarkers that we have available currently include eosinophils in the sputum or eosinophils in the blood, nitric oxide, which I find is often underutilized in a number of centers. IgE is an adequate biomarker that gives a sense of allergies, but it's not a very good predictive biomarker, nor is it a very good response biomarker, the way eosinophils and nitric oxide are. And then allergen skin testing can also play a role in terms of identifying patients who have a propensity to allergies. On top of these current biomarkers, there are other biomarkers that have been evaluated in patients with asthma. Periostin and dipeptidyl peptidase 4 have been thought of as potential biomarkers for IL-13 activity. Eosinophil peroxidase, major basic protein, eosinophil-derived neurotoxin, have been utilized to evaluate patients with eosinophilia. Urinary bromotyrosine is another biomarker that's been evaluated to indicate potentially type 2 inflammation. And then people are looking at other biomarkers, including C-reactive protein and IL-6 levels for non-type 2 patients. It's important that we utilize these biomarkers in all of our patients to evaluate what type of asthma does this patient have. And that's going to be a recurring theme. We want to understand the mechanism of disease. We want to understand the endotype of the specific disease so that we can treat patients with a precision medicine approach. Now, I said I was going to talk a little bit about the mechanism of asthma. And asthma is a complex, heterogeneous disease characterized, as we know, by a lot of features in terms of symptoms: cough, shortness of breath, wheeze, chest tightness. Now, you can get to those manifestations, those symptoms, through both type 2 and non-type 2 mechanisms. In type 2 inflammation, what we see is the presence of different allergens and other stimuli acting at the epithelial layer. And the epithelium is the first barrier of defense. It involves interactions at the epithelial layer by different stimuli that can result in production of different epithelial alarmins, including TSLP, IL-25, and IL-33. These epithelial alarmins can drive downstream innate and adaptive immune responses, including activation of Th2 cells and innate lymphoid cells, or ILC2 cells. Th2 cells and ILC2 cells are involved in the production of interleukin 4, interleukin 5, and interleukin 13. And interleukin 4 plays a role in terms of activating B cells and producing different antibodies, including IgE, IgG, IgG4, amongst others. In the presence of different aeroallergens, when two IgEs bound to a mast cell or basophil are cross-linked, that can result in degranulation of the mast cell and an allergic response with release of histamines, leukotrienes, prostaglandins, and a variety of other cytokines. That's down in the bottom left-hand corner, and we consider that a key piece of the allergic response. In addition, there's the eosinophilic piece, and eosinophils are an important white blood cell that contain a variety of different granular proteins, including major basic protein, eosinophil peroxidase, eosinophil cationic protein, and eosinophil-derived neurotoxin. Stimulated by IL-5 in the bone marrow, eosinophils end up being produced, and IL-5 plays an important role in not only in their production, but also in terms of their activation, proliferation, and survival. In addition, IL-5, along with IL-4, IL-13, and eotaxins, play a role in terms of transmitting eosinophils from the blood into the tissue. Now, we've talked a little bit about type 2 inflammation. One other component of type 2 inflammation is IL-13 mediated inflammation. As you can see, right above the IL-4, 5, and 13 that's produced by Th2 cells and ILC2 cells, you can see that that IL-13 is going back up to the epithelium where it's involved in nitric oxide production. It also goes down to the submucosal layer where it's involved in smooth muscle constriction and airway hyperresponsiveness. So type 2 inflammation is very complex. It involves a variety of different cells, from Th2 cells and ILC2 cells to B cells, eosinophils, mast cells, amongst others, as well as the epithelial cells. What about non-type 2 inflammation? Well, non-type 2 inflammation is brought forth by a variety of different stimuli, including pollutants and microbes and viruses and other irritants. And in contrast to working through Th2 pathways, non-type 2 asthma is characterized by Th1 and Th17 mediated inflammation, which often results in neutrophil activation through a variety of different cytokines, including IL-6, IL-8, IL-17, interferon gamma, and TNF alpha. These too can result in type 2 inflammatory responses. Now, a major part of our pharmaceutical approaches have really been looking at type 2 inflammation and looking at the IL-4, IL-5, IL-13 axes, as well as mast cell mediated disease. But there's a paucity, and we're lacking data on non-type 2 asthma, which is something that I think that we need to focus on as well. That brings me to the newest set of asthma guidelines. The 2023 guidelines will be released in the next couple of weeks, but let's focus briefly on the 2022 guidelines, which advocate for a step-up approach of inhaled corticosteroids, addition of long-acting beta agonists, and then advocating for a more important assessment of the severity of asthma and all the factors contributing, including other comorbidities. But they also focus on the addition of biologic therapies to the armamentarium of asthma. And this includes addition of anti-IgE, anti-IL-4, IL-5, anti-TSLP, amongst others. And so this is where we are today. An important component of this, as you can see at the top, is the importance of reviewing, assessing, and adjusting. Patients may respond, they may not respond, and you need to adjust accordingly. So the other concept that is relatively novel, which people are just starting to talk about, is the concept of remission. What is remission? Remission is a form of sustained control. Yes, we try to move patients who are not well controlled to get them controlled, but we want patients to have sustained control without any exacerbations, without any urgent care visits, with normal lung function and no symptoms. That concept of sustained control is remission. And ideally, if this can be accomplished without any therapies, then we can get into really disease modification. So remission is a state or period with low to no disease activity that can be spontaneous or a result of biologic therapy. But you need to have all of these different components addressed: lung function, exacerbations, oral steroid use, normal asthma control or ACT. And then on top of that, it is important to evaluate whether or not you're addressing the underlying inflammation. Do you have normalization of the type 2 biomarkers? So my overall approach to treating patients with severe asthma is to try to treat with a personalized approach to identify the asthma type by phenotype or endotype, and then treat with the most appropriate therapeutic strategy based on the underlying asthmatic mechanism of inflammation, and evaluate for comorbidities and optimize adherence. Now, we have several therapies that have been approved: anti-Ig therapy with omalizumab, anti-IL-5 therapy with mepolizumab, reslizumab, and pembrolizumab, anti-IL-4, anti-IL-13 therapy with dupilumab. And the most recent addition has been anti-TSLP therapy with tezepelumab, which was approved in the United States in December of 2021 and is gradually being approved in other countries as well. Now, there are other therapies that are in development: anti-IL-33, anti-IL-17, JAK inhibitors, amongst others. And our goal is to try to identify the right drug for the right patient. So what can we achieve with all of these different therapies? Well, most of the biologics have been shown to reduce exacerbations. They've been shown to reduce corticosteroids and their side effects. They've resulted in improved symptoms and quality of life. And our goal is to try to achieve disease modification to prevent asthma over the long term. We're not quite there yet, But another thing that biologics can do is address some of the other comorbidities, like chronic rhinosinusitis, nasal polyps, like atopic dermatitis. So how do we choose which therapy is best for a specific patient? How do we choose between biologics? That's where the biomarkers come in. They help predict therapeutic responses. We have to phenotype our patients. We have to choose the most appropriate therapy with a goal of delivering personalized or precision medicine. And it can always remeasure biomarkers, but it's important for us to evaluate biomarkers, the different biomarkers, that can help us determine what is the underlying mechanism of disease, what is the endotype of this patient, what is the ultimate phenotype. So we'll start off by talking a little bit about each of these different classes, then we'll move on to some of the newer classes. We'll start off by talking about anti-IL-5 therapies. Here in the middle of the screen, you can see a large eosinophil, and there are a few different therapies that target eosinophils. Benralizumab targets the IL-5 receptor. Mepolizumab and reslizumab target interleukin-5 itself. Mepolizumab was approved in 2015 in the US after 2 papers in the New England Journal of Medicine, one by Hector Ortega, one by Elizabeth Bell, demonstrated efficacy compared to placebo in terms of reduction in exacerbations. And in the Elizabeth Bell case, there was not only reduction in exacerbations by about 50%, but also a 50% reduction in steroid dose. How do the anti-IL-5s work? Well, we've already talked about the fact that interleukin-5 plays a role in eosinophil pathophysiology. And what we want to try to do is we want to try to block eosinophil production, activation, proliferation. And by blocking IL-5, we can do that. A similar thing was found with reslizumab. Reslizumab is administered intravenously, 3 milligrams per kilogram. It's dosed based on body weight. And here again, we saw significant reduction in exacerbations, but also accompanied by improvements in lung function. Benralizumab works by blocking the IL-5 receptor, and it's effective as a therapy, not just in terms of blocking IL-5 from binding to its receptor, but it can also result in killing of eosinophils, because when benralizumab binds the IL-5 receptor on the eosinophils, the body's immune system recognizes it as foreign and will kill the cell that it's attached to through antibody-dependent cell-mediated cytotoxic effects. Now, these important phase 3 studies by Jean Bleecker and the late Mark Fitzgerald demonstrated a robust reduction in exacerbations, whether patients were given 30 milligrams every 4 weeks or 30 milligrams every 8 weeks after the first 3 doses. But what they demonstrated was getting patients down to around 0.6 to 0.7 exacerbations per year, which is significantly better than placebo. In addition, an important steroid-sparing study with benralizumab in patients with severe asthma was published by Parham that year in the New England Journal of Medicine in 2017. In this study, patients who were receiving benralizumab were able to taper their corticosteroid dose by 75% compared to only 25% with placebo, as is shown in the top figure. But despite the fact that these patients were coming off of corticosteroids, benralizumab, whether it was given every 4 weeks or every 8 weeks, demonstrated a significant reduction in exacerbations in those patients on the order of 70%. Now, what about targeting type 2 cytokines otherwise, going beyond just IL-5? Well, dupilumab is a monoclonal antibody that binds the IL-4 receptor and prevents both IL-4 and IL-13 from binding to the receptor, and therefore blocks many of the activities of interleukin-4 and interleukin-13, including nitric oxide production, airway hyperresponsiveness, mucus secretion, as well as trafficking of eosinophils. Now, dupilumab was first studied in a paper in the New England Journal of Medicine by Sally Wenzel about 10 years ago. And in that study, there was a withdrawal study design in which patients were randomized to receive dupilumab or placebo, and then gradually have their inhaled steroids and long-acting beta agonist taper. By the end of the study, during weeks 9 to 12, patients were only on dupilumab or placebo. And what was demonstrated was a significant reduction in exacerbations in these patients, an 87% reduction in exacerbations. As you can see on the left-hand side, the cumulative exacerbation rate continued to increase when patients were on placebo, with a very slow increase in the dupilumab arm. In addition, one other thing that's been observed is that there's a significant improvement in lung function with dupilumab, even when it was administered on top of inhaled steroids and long-acting beta agonists. This improvement was seen early on and was sustained throughout the 52 weeks of the study. In fact, when looking at the phase 3 data, you can see that both the 200 milligram every 2-week dosing or the 300 milligram every 2-week dosing was very effective at reducing exacerbations in this large 1,900 patient study. The annualized rate of exacerbations overall was lower with dupilumab compared to placebo, but it was particularly lower in patients who had more than 300 eosinophils, more than 150 eosinophils, or more than 50 or 25 parts per billion of nitric oxide. And that is important. It gives us a sense of who is most likely to be a responder. The people most likely to be responders are people who have high eosinophils or high ENO, patients who got type 2 disease. In addition, dupilumab significantly improved lung function over the course of 52 weeks. And that's important to recognize as well. Not only is it improving exacerbations, it's also improving lung function. And the 96-week TRAVERSE study, which was a long-term follow-up of patients treated in the earlier studies, demonstrated sustained improvement in lung function over the course of 96 weeks. And patients who had not been given dupilumab in the clinical trial but were on placebo and were crossed over to get dupilumab, they were able to catch up and have significant improvement in their lung function as well. Most recently, data with dupilumab in children was published by Len Beccarrier, and it showed very similar results. Patients who had high eosinophils, patients who had high nitric oxide were much more likely to respond, and they responded well with regard to each of these different outcomes, not just exacerbations, but also FEV1, as well as asthma control questionnaire scores. So that's where we are now. We've had anti-IgEs approved for 20 years, anti-IL-5 for the last 7 or 8 years, anti-IL-4, 13 for the last 4 to 5 years. And where are we now? Well, the most exciting therapy that's really emerged in the last couple of years is tezepelumab. And this phase 2 study by Jonathan Corin demonstrated that 3 different doses of tezepelumab were able to reduce asthma exacerbations by 60 to 70%, and regardless of the dosing strategy utilized. But what was most interesting to me was, while it was effective in the overall population, it seemed to be effective in both type 2 and non-type 2 patients, in patients with low eosinophils and high eosinophils, in patients with low nitric oxide and high nitric oxide, in patients with high Th2 status and low Th2 status. The Navigator study was a phase 3 study that we participated in which patients received tezepelumab or placebo. And at the end of the 52-week period, there was a 56% reduction in exacerbations in patients treated with tezepelumab. Interestingly, this is the first drug to show efficacy in terms of exacerbations in patients with low eosinophils. Patients with less than 300 eosinophils, there was a 41% reduction. And when we look at other subgroups, even those with less than 150 eosinophils tend to have some efficacy, about 39% reduction in exacerbations. Same thing was observed with nitric oxide and also patients who were allergic. So this therapy seems to be an effective choice for patients with eosinophilia or nitric oxide or atopy as measured by IgE, or in patients who have those absent. What did Tezi do to these patients? Well, it lowered blood eosinophils. And that makes sense because if you think back to the cartoon figure I showed you before, in which there was TSLP stood at the top of the inflammatory cascade above IL-5. If you block TSLP at the top of the inflammatory cascade, you're less likely to make IL-5 by Th2 cells and ILC2 cells. And so eosinophil counts are likely to go down. The same thing can be said about nitric oxide, which we think is IL-13 mediated. IL-13 mediated nitric oxide production also went down, as did total IgE levels. And this is the first therapy that results in depletion and reduction of all three of these key biomarkers. Now, there was an oral steroid study that I led called the SOURCE study. And unfortunately, this study failed to meet its primary endpoint. While 54% of patients treated tezepelumab were able to reduce their steroid dose by 90 to 100%, only 46% of patients treated placebo were also able to reduce their steroid dose by 90 to 100%. So there was very strong, robust placebo effect that was seen at all different dosing intervals. And it's thought that this lack of difference may be in part due to significant placebo effect or from patients having multiple opportunities to taper their corticosteroids, even getting them during a flare. So it is important to evaluate that. It is also important to recognize that steroid reduction isn't the only meaningful outcome. There were also reductions not only in oral steroids, but also reduction in exacerbations in many of these patients. There was a 31% reduction in exacerbations. Lung function improved by 260 milliliters compared to placebo, and ACQ6 was also significantly better, as was AQLQ and asthma symptom diary scores. When we look at the Cascade study, which was a biopsy study where patients were given tezepelumab and had bronchoscopy done before and after getting tezepelumab, we demonstrate that there's significant reduction in airway tissue eosinophilia. Bronchoscopic biopsies showed that in patients with tezepelumab, there was a reduction in tissue eosinophils. This was not seen with neutrophils, T cells, or mast cell tryptase positive or chymase positive cells. So there is an opportunity to treat patients, reducing their tissue eosinophils, but not necessarily having a significant effect on neutrophils or T cells, which is what you don't want to do in any case because you want patients to not have potential risk for infection. I'll share with you also the recently presented long-term data from the Navigators, patients from the Navigators study. And these are patients who randomized to continue on to tezepelumab if they're on placebo or continue getting placebo over the long term. And what we found was over the course of 104 weeks, there was still sustained efficacy, 58% reduction in exacerbations. And in terms of hospitalizations, there was a 79% reduction. So what I've shown you with all these therapies is that we have a broad group of options now. And this is new over the last 7 or 8 years. We have dupilumab, omalizumab, benralizumab, mepolizumab, reslizumab, and tezepelumab available. They're indicated for different age groups. As you can see, dupilumab, omalizumab, and mepolizumab can be utilized down to age 6, and reslizumab only above age 18. In terms of frequency, there's some differences there. Some are every 2 weeks, some are every 4 weeks, some are every 8 weeks. And there are other approved indications for some of these: atopic dermatitis, chronic rhinosinusitis, urticaria, nasal polyps, EGPA, chronic rhinosinusitis and nasal polyps. And they're approved in a variety of different countries. But what can these biologics do? Well, they've been shown to reduce exacerbations. They've been shown to reduce oral steroid dosing. They've been shown to improve quality of life, and they've been shown to improve lung function. What about some of the other new therapies? Well, a couple of CRTH2 antagonists, including GB001 from Gossamer Bio and fevipiprant from Novartis, failed to meet important endpoints in phase 3 and are currently not being pursued for this indication as of now. JAK inhibitors are another oral therapy. They're downstream of most asthma-related cytokines. It's currently in phase 2. Itepekimab is an anti-IL-33 therapy. It's been shown to reduce exacerbations versus placebo. And it's comparable to placebo in many ways, but less effective in combination with dupilumab. In the anti-IL-33 study, we had 4 different arms. We published these in the New England Journal of Medicine a couple of years ago. Patients received either dupilumab, itepekimab plus dupilumab, or placebo. And while the itepekimab group did better than placebo, as did the dupilumab group, interestingly, the combination of itepekimab and dupilumab didn't do as well as either agent alone. And so we have some other encouraging data in COPD. Currently, anti-IL-33 therapy with itepekimab is being studied in COPD. Another anti-IL-33 therapy is astegolimab, and that's currently in development as well. In the phase 2 study, you can see that there's, regardless of the doses, there's sustained reduction in asthma exacerbations across the board. IL-25 blockage also holds some promise, but there aren't a lot of clinical data, but there are some mouse model data that suggest that it's an effective therapy with lowering of IL-5 and IL-13 compared to placebo. Another exciting therapy that's on the horizon is depemokimab. That's in phase 3 right now, and it's administered every 6 months. Can you imagine taking a biologic every 6 months instead of every month? Dexpramipexole is an oral therapy. It's been developed for ALS. It is an uncertain mechanism, but it's been shown to reduce eosinophils and in one study, improved lung function. Lastly, I'll just put in a plug for our network, the PRECISE network, Precision Interventions for Severe or Exacerbation-Prone Asthma. We've been studying imatinib, which is a KIT inhibitor, anti-IL-6, tavasonstat, which is a G-SNOR inhibitor, JAK inhibitors, bronchovaxim, and medium-chain triglycerides. JAK inhibitors, I think, are the most exciting of these to me because these Janus-activated kinases provide signaling for all of the key cytokines, including IL-4, IL-13, IL-5, GM-CSF, and others. And so if you can block the signaling from those cytokines, that might result in better outcomes and less burden of disease. And this has been demonstrated that JAKs are elevated in some patients with allergic inflammation and others. So I'll just finish up over the next few moments. It's important to remember that asthma therapies, response to asthma therapies is quite variable, and we need to understand who responds to what. We now have multiple novel biologics therapies that can treat patients with severe eosinophilic asthma, with type 2 asthma, with non-type 2 asthma even. So how do we decide which therapies work best in which patients? First, you have to do an extensive workup, and you have to endotype your patients. You need to check IgE, you need to check FeNO, you need to check eosinophils in the blood and in the sputum. DPP-4 and periostin aren't really commercially available, nor are they that useful at this point. But think about all the different kinds of patients. Patients with allergic eosinophilic asthma, you won't be faulted if you choose any of these therapies. Anti-IgE will work for the allergic component, anti-IL-5 will work for the eosinophilic component, anti-IL-4/13 will work particularly if the nitric oxide is high, and anti-TSLP would also work across the board. It works in both type 2 high and type 2 low. Patients with allergic non-eosinophilic disease, well, if they're non-eosinophilic, they won't be a candidate for anti-IL-5, but there's no reason why you shouldn't consider one of the other therapies. Patients who are eosinophilic but who are non-allergic, they won't qualify for anti-IgE, or if they don't respond to anti-IgE, or if they're out of range of dosing of anti-IgE treatment. So think about that in terms of those kinds of patients that are eosinophilic but non-allergic. Other factors that you should think about include decisions about patient comfort with new agent versus older treatments with more expertise. Lastly, I'll just finish talking about non-type 2 disease. Azithromycin given 3 times a week, bronchial thermoplasty, and tezepelumab are now the only options that we have. We clearly need to understand this entity better, and perhaps we'll develop novel therapies with some of the novel biomarkers that we've been studying. What about targeting IL-23? Well, this was recently studied in the New England Journal of Medicine and actually did worse than placebo when risankizumab was administered. So I'll leave you with the following questions. How do you choose whether or not to use a biologic? Well, if the patient's poorly controlled, if they're adherent to therapy, if you've addressed their comorbidities, if they're not on oral corticosteroids, those are the kinds of patients you should think about, or if they're on oral corticosteroids. So the way I choose between the biologics is I look at the biomarkers, I try to identify the dominant biomarker, I then look at type 2 comorbidities, chronic sinusitis, nasal polyps, and the like, atopic dermatitis, eosinophilic esophagitis. And if the patient responds to initial therapy, then you could always consider switching. The important thing is to move from our one-size-fits-all approach to the stratified approach where we are now to a more personalized approach in the future. We're not quite there yet, but I feel like we're moving there. And as we learn more about the genetics of these patients, we'll gain much more insight in that regard. In some, current biologics are effective, but they don't completely eliminate exacerbations. Our current understanding of asthma mechanisms remains somewhat rudimentary. We have novel therapies that work upstream, including anti-TSLP and anti-IL-33. But we still need good therapies for non-type 2 disease. We still need to use biomarkers. We need more biomarkers. And we need to appreciate that asthma is very dynamic. So thank you so much. I'd be happy to take some questions. I know that I'm on time, and I'd be happy to answer any questions that anybody has. Thank you.
Well, thank you so much, Professor Wechsler, for this wonderful presentation. We have a few questions in the chat box, so I can merge a few of those because some are on the same topic. The first one is about the dose and duration of biologics, and in fact, there is another one on how long should you prescribe, or how long should a patient take a biologic if, for example, after a few years is still stable? Is there a possibility to stop sometimes some of this biologic? I know it's been tried with omalizumab, but what is your opinion about that?
Yeah, I think if a patient has achieved remission on a given therapy, you have to have a discussion with the patient. Are they happy and are they comfortable continuing the therapy? We don't have a good appreciation. We don't think there are long-term risks of these therapies, but perhaps there are. And I think it's important to think about potential long-term risks of these therapies for our patients. So what I would recommend would be having a discussion with the patient, evaluating what to do. I usually don't stop a therapy if it's working well. I don't stop it completely. What I do in an off-label manner, and again, this should be studied, is I increase the interval. And if patients can tolerate increasing intervals, then perhaps I'll feel more comfortable stopping them down the road.
Yeah, that's right. And of course, I think with omalizumab, at least it was shown that if it was stopped and then reinstalled, the effect is as good as at the first time. I think there was no loss of effect finally.
So each biologic is a little bit different. When patients stop the anti-IL-5s, they can have a recrudescence of eosinophilia in a lot of cases. So you need to be on the lookout for that.
That's right. And if a patient has a very good response, let's say that he seems to be in clinical remission, what do you do with the other medication? Do you taper down the high-dose ICS and the other drugs? Do you have a schedule for that, or do you keep a minimum dose of something?
I try to keep my patients on a minimum dose of an inhaled corticosteroid and a bronchodilator unless they're really, really well controlled. Because there are other mechanisms of inflammation that are going on that the inhaled corticosteroids may be addressing and that the bronchodilators may be addressing in terms of bronchoconstriction. So I would sooner stop a biologic than stop an inhaled steroid long-acting beta agonist. But again, this needs to be an individualized discussion with each patient. And I can tell you that many patients will stop them on their own. And I find that when they stop their ICS and LABA, oftentimes they come back with more symptoms while they're on the biologic.
That's right. So before asking my colleague, Professor Fulvio Braido, to ask questions, there is another one here. What are your criteria to determine if there is an insufficient response to a biologic and then think about switching to another one and so on? Do you have a specific criteria to look at that?
Yeah, so I look at a variety of different outcomes. I always think it's important to ask, what was the reason that I put the person on the biologic to start with? Was it because of exacerbations? Was it because of poor lung function? Was it because of persistent symptoms? Was it because of comorbidities? Was it because of oral corticosteroid use? And then I go back and I see, how did the patient respond? Now, some patients are complete responders, some are partial responders, and some are non-responders. But you have to take into account that just because they didn't improve in all domains, it doesn't mean that they're not responding. So it's important to think about that in that context. You might have some response in terms of steroid reduction, but may not have some improvement in FEV1. But
Oops, I think we lost Professor Wechsler.
Yeah, I'm back. My computer died. So I'm glad I have my cell phone to work.
Thank you, Michael. Only a few really short questions, but your presentation was really amazing. First of all, you are in the stratified medicine, but from the dose perspective, it seemed that the one size fits all. What is your idea? Because we start our practice with omalizumab, with a dose, weight, and so on related, and now we are moved to a really one dose for all the patients. What is your feeling about this?
So I think that we need to identify what's the best drug for each patient, and there's a lot of factors that go on. And we've come to recognize that there's multiple mechanisms of disease. And you can give a patient with eosinophilic asthma an anti-IL-5, and you'll address their eosinophilic component of their disease. But you may not be addressing the allergic component. You might be giving someone with a high nitric oxide, dupilumab, an anti-IL-4/13 therapy, and that might address some of their disease, but it may not address some of their non-type 2 manifestations. So I think what we have is better than what we had, and we're getting better, but we're still not there. We still have, in the United States, every year, despite all these biologics, 1.8 million emergency room visits for asthma, 500,000 hospitalizations for asthma, and still 3,000 people die from asthma every year in the US. And that's despite the fact that we're spending, you won't believe it, $80 billion a year taking care of patients with asthma. So we have better tools than what we had, but we still need better tools yet.
Thank you. Another key question. You have related you state that the remission is a prolonged control. We can define a time of several biomarkers, obviously, symptoms, function, flows, and so on. We can define a time, 1 year, 2 years, 3 years.
We're still in discussion about how to define remission. And we generally think of sustained remission as 1 year. That would be the lower limit of what I would consider if someone is stable without exacerbations, without symptoms, without lung function. Having a longer sustained remission, that would really suggest disease modification. Now, we have a lot of good therapies, but unfortunately, when we look at the data about remission, tell me what you would expect would be the percentage of patients who actually achieve some degree of remission. It's only about 15 to 30%, depending on the study, depending on the biologic. So it tells us that we need to do more. maybe combining biologics, maybe targeting more broadly, maybe identifying better biomarkers that we can then target our patients more with. We don't do a good job with the non-type 2 diseases. And that's another important component. These diseases are very dynamic, and they involve both type 2 and non-type 2 mediated exacerbations. So you might take care of the allergies with any of the type 2 biologics, but you may not be addressing virally mediated exacerbations. And that's a challenge for us. Maybe we need to give bronchovaxum or some other approach to try to reset the immune system.
Thank you. A really last question. It is really interesting, the placebo effect in all the biologic trial, and the data that you've shown about the OCS reduction in the trial with the TEP is real. Which kind of other issue besides adherence to treatment with ACS LABA we can envisage in order to explain really this larger effects?
So I published a study on the placebo effect in asthma in the New England Journal of Medicine in 2011. And what we found was that there's a significant placebo effect regardless of the type of placebo. In that study, we gave albuterol, but we also gave sham albuterol or placebo albuterol. We also did sham acupuncture or placebo acupuncture. And both of those interventions made people feel better. It didn't affect their lung function to the same extent, but it tells me that we need to spend more time with our patients, reassuring them, and that there's probably other components of mental health that we need to address as well. Anxiety, depression, and if we can address some of those things, then we might have an impact on managing those patients. We also need to do a better job of addressing a lot of the comorbidities, because those can also play a role, whether it's vocal cord dysfunction or inducible laryngeal obstruction, as it's now called, or whether it's any of the other comorbidities. Those are all important components. So the placebo effect, I think, is important. It suggests that we can have an impact by reassuring our patients. But the placebo effect also, what we saw is patients are often taking their inhalers more adherently. That's another important piece. And then there's just the clinical trial piece where patients are paying more attention to their disease. They're spending less time, doing things that could be making the underlying disease worse.
Well, thank you very much, both of you, for this discussion. And thank you very much, Professor Wechsler, for this very interesting presentation. I think we have to follow these developments in the next little while. Asthma is a field where research is still ongoing at a very large scale. So thank you so much for this presentation, and thank you those who attended this conference. Thank you so much.
Thank you, everybody. Have a good weekend.
Good weekend.